Pardon? We rung the bells? Good morning, delegates. If you could take your seats, please, so that we can get the first session of the day underway. I hope you all had an enjoyable Friday night in Brisbane. We certainly had a fabulous dinner, being guests of the doctors in training, to listen to Ms. Gillard, who gave a very inspiring exposition on leadership and how you manage it and how you build towards it in your life. It was a fabulous presentation. So our first session this morning is on quality public hospital services, funding capacity for performance. And I'll hand over to the President, who is chairing this session.
Well, thank you, Anne, and good morning, everyone. Welcome to this session on quality public hospital services, funding capacity for performance. What our distinguished panel here to discuss could not be more important to Australia's public hospitals and to our health system more broadly. We are facing a crisis in Commonwealth funding for public hospitals. This is a man-made crisis brought about by a failure of the political process at the Commonwealth level to produce common sense outcomes required for the ongoing functioning of public hospitals and the health of the community. The collateral damage from that failure is insufficient and uncertain funding for public hospitals to meet the demand for services and timeliness and quality standards. Hospital care is not a discretionary good for patients, for clinicians, for hospital managers, or for governments. Hospital funding is not an elastic concept where levels of funding can be determined according to political demands and budget pressures. So where do we stand currently with public hospital funding? The Commonwealth's contribution has fluctuated. Under health reform, the policy pendulum has swung from new ideas addressing growth to old arrangements for maintaining funding public hospital services. Currently, the Commonwealth is withdrawing from the commitment to sustainable public hospital funding and to meet an equal share of growth in public hospital costs. It is also withdrawing from activity-based funding, or ABF, as the basis for pricing and funding public hospital services. In the 2014-15 budget for the Commonwealth Government, it reduced funding for public hospitals by $1.8 billion to 2017-2018, with further reductions of $940 million in the December 2014 budget update and $423 million from 2015-16 to 2017-18 in the 2015-16 budget. The Commonwealth Government also announced that from 2017-18 it would move to an approach of indexing its contribution to hospitals funding by a combination of the Consumer Price Index and population growth. The Commonwealth Treasury Department quantified the financial impact of this change as a $57 billion reduction in Commonwealth funding for public hospitals over the period of 2017-18 to 2024-2025. The government is refusing to shift from its new hospital funding arrangements based on indexation and population growth to apply from 2017-18. These continuing budget cuts and reductions are not only impacting on the ability of public hospitals to provide services, they are also reducing the funding base to which indexation will apply under the government's future arrangement for public hospital funding. The AMA has been vigilant in tracking Commonwealth funding commitment to public hospitals and reporting the saga of ever-reducing funding at each budget update. This is shown graphically in the AMA Public Hospitals report card this year. AMA Federal Council has been active in monitoring public hospital funding and ensuring the AMA has relevant and up-to-date policy. In March 2015, the Federal Council passed a resolution opposing the government's reduction in funding for public hospitals in the 2014-15 budget and the decision to restrict Commonwealth funding for public hospitals to indexation by the CPI and population growth. This week, Federal Council resolved that any future basis for Commonwealth funding and for public hospitals must, at a minimum, include adequate provision for population growth and demographic changes and annual indexation at a rate that is relevant and appropriate to the health, goods and services costs incurred by hospitals. CPI is not the right index for this. Related to public hospital funding, Federal Council also resolved the government should continue to use the capabilities established for activity-based funding to monitor hospital activity and complement them with quality measures. This policy session will firstly consider how we can address the performance of our public hospitals, separate to and as a foundation step before considering questions of funding. Our speakers will then consider public hospital funding from the perspective of a larger and smaller state, from within the political and clinical context respectively. After we hear from our three speakers, we will have a plenary Q&A session with the opportunity to ask questions through the mechanism that is in the conference proceedings, but I'll go through that a little bit later. Our first speaker is Dr. Diane Watson. Diane Watson is the inaugural Chief Executive Officer of the National Health Performance Authority, taking up the position on the 1st of June 2012 after being interim CEO since February 2012. The Performance Authority supports health system improvements through independent reporting on the comparable performance of more than 1,000 public and private hospitals and primary health care organisations. Its information is available on the My Hospitals and My Healthy Communities websites. We've asked Diane to examine how hospital performance is currently measured, illustrated by recent analyses undertaken by the Performance Authority. We might consider what this information means and how it is used in the context of public hospital funding. Dr. Watson's expertise and formal role is focused on health performance. She has no role in setting Commonwealth funding for public hospitals or other health services, so we'll spare you from any criticism, and is not here to speak on funding issues. Thank you, Diane.
Thank you very much for the opportunity to present to you the work we've been doing over the last number of years, 2 years in particular, releasing information about health and care in local communities and public and private hospitals right across the nation. You heard all the statistics yesterday, indeed, that I don't need to prosecute the argument that Australia is a very, very lucky place to live in terms of health and health care. Our healthcare system, when you consider it relative to others internationally, is rightly considered among the best in the world. We are indeed among the healthiest populations in the world, and indeed our spend on health is relatively modest relative to other comparable countries. However, we do see that there is a slow in health spending in Australia, and indeed we share this experience with many other countries in the world. And indeed it's most acute when you look across nations, comparable OECD nations, when you look at health spend as a percent of GDP. And in the last number of years, you see a plateauing across all those countries, an experience unprecedented if you look at OECD data trends over the last 30 years. However, I would say at the same time that focusing on national statistics and indeed encourage us to view health systems as really monolithic entities that provide uniform care. And the truth is that each nation's hospital and health services deliver a wide variety of experiences to people who work in local communities. In Australia and elsewhere, some hospitals indeed are much, much more efficient than others, and we see variation in access and we see variation in quality, and these represent opportunities to learn, as I'll illustrate today in a number of slides to you. The trouble is that until now, until the most recent years, with the establishment of the authority, prior to that, we had national statistics that didn't allow us to see uniformly across the country which hospitals were operating more efficiently, so that indeed we could learn from each other. The Performance Authority now for just over 2 years has been releasing information to provide information on an access, quality, and effectiveness right in small communities right across the country. We provide information for Medicare locals, for small units of 300 units of geography right across the country, as well as information on access, quality, and efficiency right across hundreds and hundreds of hospitals in the nation. Our reports are structured very uniquely from other information organizations, I would say, and we do this now because we know that we work in an information-rich, data-rich environment, and that time is of the essence. So this slide is here just to illustrate to you that our reports and our websites are very, very graphically oriented, so you can learn very quickly about variation across your country in terms of health and care experiences, as well as variation across hospitals. The picture there of Australia is just there to represent information, for example, on our My Healthy Communities website, where over the last 2 years we've provided more than 120 measures of health and care in local communities. Information, for example, wait times for GPs, wait times for specialists, cost barriers for access to GP, pharmaceuticals, dental specialists, percentage of patients who have chronic conditions, percentage of people who are high users of GP, local variation in infant mortality, smoking, obesity, etc. More than 120 measures now available uniquely for the first time in the country for each local community, and we've done that with the existing information systems that heretofore have been untapped to be able to provide that information to show the variation in practices across local communities. The slide on the right is just representative of our hospital performance reports. This one is in the area of cancer wait times for surgery for malignant breast, bowel, and lung cancer. When that report was released, it was really a time of celebration. Interestingly enough, we do very, very well across the country in every hospital, with the exception only of a handful or less than a handful of hospitals in wait times for those important cancer surgeries. But I'll tell you today, we haven't created a report or haven't featured it, but it's on our website. This is not the case for other areas of surgery, for example, hip, knee, CABG surgeries, etc. So let me go through a couple of our reports and show you what we now know, which we didn't know 2 years ago. A couple of years ago, this was our first report. A couple of years ago, there was a national targets and state targets set up for emergency department performance. And let me just illustrate this slide, because I'm going to go through a few that have the same kind of format. Each one of those columns is a different type of hospital, a different type of peer group for emergency departments. And that slide represents about 140 emergency departments across the country. The very first column is all the major metropolitan emergency departments in the country. And that y-axis, those numbers along the vertical, are the percentage of patients across those major metropolitan hospitals who saw patients and were allowed them to discharge or had them discharged within 4 hours of arrival. We had a very, very aspirational target that was set with national consultations, and I've spoken with the committee, and it was set in absence of understanding where every hospital in the country sat. When we released this report after the establishment of that benchmark of 90%, lo and behold, 85% of patients seen in major metropolitan hospitals. What's performance look like in major metropolitan hospitals? Anywhere from 30 to 70%. Okay, you might say, well, we could do it, why can't you? But remember, emergency departments are also a function of the system in which they work. They're a function of the performance of primary care and agent care, and how pharmaceuticals and access and universality. In Australia, there was not one hospital except two small, very small regional hospitals that had 90% of patients within 4 hours. No one had demonstrated that it indeed was possible. Very shortly after that first report, we put an interactive together on our website. This illustrates a system, I would say, with lots of experience with watching system change, a system under dramatic shifts in performance in its major metropolitan hospitals. Each one of those columns is a quarter, and each one of those dots is a hospital, all major metropolitan, and you can track them on our website and see system changing. No longer within about 4 or 5 quarters did we have any hospital in the country with less than 40%, and that happened within a couple of quarters. see the peer group, that line for each one, it's tracking up and up and up, and we're starting to get hospitals just within 4 or 5 quarters approaching 90%. But what was happening is all that was camouflaged by national and state numbers, which weren't shifting as fast as performance at each of the hospitals. So we didn't see much change, or we thought not much change was happening. And I said at the time that we released this report that there are indeed dramatic shifts across major metropolitan. You can talk to the department, as we have, and people who work at that hospital know exactly why that's the case. And we look at the data, and the data match their stories about how they change. So exemplars in the speed of change. Right from 30%, it was the lowest in our first report, came up to 60% within about 5 or 6 quarters. Just to move on from issues of access to one of quality, this is just an example of where we spent probably 5 or 6 months creating peer groups for healthcare-associated infection risk in hospitals, so that you could compare hospitals relative to other similar hospitals based on the mix of surgical procedures that are undergone in that hospital and the mix of the vulnerability of patients given their diagnostic profiles for risk of healthcare-associated infection. Only to find, after doing all that work and putting hospitals in other similar risk categories, that we have 2 to 3-fold variation in risk of healthcare-associated infections across our hospitals, as illustrated in that slide. We all know the cost to patients, and we all know the cost to the healthcare system of these very, very serious infections. Opportunities to learn from each other and to show clinical and management leadership in reducing these types of safety and quality issues within our healthcare system. I just wanted to spend a couple minutes on the latest report that we've released from the Performance Authority, a first in Australia, and from my colleagues internationally, I understand it's a first internationally where so much time and effort has been put forward to understand the relative efficiency of a nation's largest public hospitals, in this instance 80 to 90 of the largest hospitals in the country. It shows for the first time, after extensive work which I'll go through in a minute, which of Australia's largest public hospitals have the lowest cost for admitted patients and which have the highest. The differences are considerable across the country. Operational cost in providing similar services to similar types of patients can be nearly twice as high at some major metropolitan hospitals compared to others. And this is similar when you compare large hospitals to each other in major and/or regional areas. Let's spend a few minutes then on that report. Boy, this is tricky. The report was a combination of a couple years of work from the Independent Hospital Pricing Authority in partnership with ourselves. We had 3 leadership committees, including about 35 people, one of jurisdictions, one of healthcare managers and clinicians, and the other one of technical experts. We also commissioned and undertook with the Pricing Authority 3 independent reviews of finance and accounting processes at hospitals across the country to make sure that they were in accordance with national guidelines for uniform costing, and where they weren't, they were accounted for in the methods. The report looks at operational costs, so we exclude property costs, etc., property and equipment, etc. So operating costs of hospital and where they were comparable. So not full costs, but a subset of costs, and indeed the vast majority of costs where they're comparable across hospitals. We looked just at admitted patients, and then we spent 5 or 6 months because we knew about the variation in length of time in ED, and so we looked for admitted patients. We took their costs in ED and attached them to their admitted patient costs to come up with 2 different measures. No matter how we cut the data, no matter the kinds of sensitivity analysis that we did, at the end of the day, major metropolitan, almost 2-fold variation in relative efficiency of comparable operating costs for similar patients and similar procedures. Let's look at some of those procedures just now. Here's an example of the 16 conditions that our clinical and healthcare managers selected for us to do some specific profiling. They asked us to look at relative length of stay so clinicians across the country could understand the materiality of variation in length of stay and to look at the differences in cost. So here's an example, knee replacements without any complications or comorbidities, about 5,000 of these admissions in the country without complications or comorbidities. Variation in length of stay, almost double from one hospital to the other. This is just the acute phase of admission. Length of stay anywhere from 3 to 8, depending on the hospital that you stay at. And this is all the patients in a hospital, averaged across all those patients. Some hospitals 3 days, some 8. What's the differences in cost? Some hospitals, operating costs that are comparable across hospitals, the majority of operational costs, anywhere from $10,000 to almost $30,000 for knee replacements in the nation. Let's look at an example of general medicine, COPD, 20,000 admissions in the country. Variation in COPD, length of stay, acute, 3 days to 6 days. Variation in cost, $3,000 to $10,000. So I know all you doctors out there, because I work with you for many, many years, will say, oh, well, this might depend on primary care in the community and the types of patients that we see, et cetera. So we took a number of simple, relatively simple conditions, procedures in hospitals that are very, very common and have very, very similar patient profiles. And this pattern that I just described to you is ubiquitous no matter where you looked across the 16 clinical conditions. So let's look appendix, but you see this in gallbladder, et cetera. In this instance, 13,000 admissions, probably about 25,000 bed days in the country. Average length of stay anywhere from 1.5 to 3, so double. A variation in costs anywhere from 4 to 10. Okay, you might say, well, what does the day matter? I'll tell you, if you take those hospitals with the 3 days and you take them down to the average, you can save what equates to probably, and you could aggregate all those bed days together and put them in one hospital. You have a bed or two for 10 days, or for 10 years, excuse me. Okay, so I know that we can't do that, but our clinical advisory committee suggested that we put this information together with length of stay to be able to illustrate to you that across all of the conditions that we see in hospitals, even marginal changes in your models of care while maintaining quality can make material differences in the relative efficiency of our healthcare system right across the country. One of the great things that I love about this job is being able to illustrate some exemplar performance examples. We heard about Princess Alexandra. I talked about it a minute ago. There has also been some, and I also talked about the cancer surgery wait times. There's also been some great success illustrated in the healthy communities area. Lower Murray, an example. Immunization rates, if you've been reading about it in the newspapers, that was all instigated by us by providing immunization rates available now to doctors and to parents and to daycare workers right across the nation. And you can look that up for postcode where there's not privacy issues. Lower Murray took that information, 5-year-old, its immunization rates were 86%, 1 year later, 94%. They've taken a community at high risk for vaccine preventable conditions for its 5 years old and put it into one of the highest performing categories of performance for immunization for 5-year-olds in just 1 year. Nepean Blue Mountains, I love this story, and so does the chief executive who worked there, who I talked to about it. This is infant and child mortality rates. We've all been told for many years, and indeed it's true on average, but not necessarily in all cases, that in regional and remote areas of the country and in lower income gradients that you see higher infant and child mortality rates. That does not have to be the case, and Nepean Blue Mountain proves it to us. Middle to lower income regional community, its infant and child mortality rates are lower than many and most high-income metropolitan communities in the country, and the chief executive and staff in Nepean Blue Mountains can tell you exactly why that is the case. So thank you very much for your interest in performance information and how we can leverage the existing information systems in a nation to provide insights to you and opportunities to learn to improve access, quality, and efficiency of our health system. Thank you.
Well, thank you, Diane. We certainly look forward to your reports at the AMA, and I think it's a great tool for not only some of the arguments that we need to make, but also to improve directly patient care. I'd like now to introduce Associate Professor Tim Greenaway. Tim is President of the Tasmanian AMA and Secretary of the Tasmanian Salaried Medical Practitioners Society. Since 2000, Tim has had a number of roles at the Royal Hobart Hospital, including Director, Department of Diabetes and Endocrine Services, Deputy Director, Division of Medicine, and Medical Co-Director, Clinical Services Medicine. He currently holds the position of Director of Clinical Endocrinology. Tim is also Clinical Associate Professor in the School of Medicine, Faculty of Health Sciences, University of Tasmania. He is active in undergraduate and postgraduate medical education and basic and clinical research. He is also the Deputy Chair of the Health Council of Tasmania and the Chair of the Healthy Tasmania Committee. Gosh, Tim, you're getting busy. Tim will present a perspective on public hospital funding for Tasmania as a smaller state with relatively stable population numbers but significant demographic changes in age and health needs. Thanks, Tim.
Thanks, Brian. Thank you, Brian. Thank you to the organisers for inviting me to speak to give a smaller state, I would say the smallest state's perspective. Diane had a couple of geographical slides. I've got one. Just to orientate you, I don't have the laser pointer, but we're up the top of the world. The problems facing the public health system and the health sector generally are well known, and increasing demand is leading to rising health expenditure. We have an ageing population, a population with increased chronic disease. There is increased expectation of health services and increased volume of treatment. And I have this slide from my colleague Professor Peter Brooks. It's called the sustainability funnel. In terms of the separation between demand and funds and staff available for health service delivery, there is an increasing gap, and this is something that faces all of us every day. Peter also has summarised quite succinctly the current status of Australia's health system. We're short of staff. We're medically hospital focused, and I can say this working in a public hospital. We're not technologically enabled. We're specialist focused, and I can say this as a specialist. We're not patient centred, and we're certainly expensive. What could be possible healthcare responses to an ageing population with increased chronic disease? Well, there could be increased healthcare workforce and budget. We could import low-cost healthcare workers from developing countries. I don't think any of us would favour that approach. We could increase responsibility of individuals or family members, prevent diseases associated with long-term morbidity, and develop solutions that replace functions currently provided by healthcare workforce. The current funding arrangements are piecemeal, as you know. I won't go through this in any detail. It is a mixture of state and federal funding, which leads to inefficiency, duplication, and cost shifting. I thank Martin Mullane for these slides. As our President has already told you, and as I'm sure you're already aware, the current federal government budget has removed another $423 million from public hospital funding between 2014 and 2017-18. But Tasmania has in fact fared a little bit better with an additional $21 million over 3 years from the previous MyFO budget estimates in December. Why is Tasmania special? Well, we're actually a small state with big problems. These are figures that Martin Goddard provided me from the Australian Institute of Health and Welfare from 2012 to 13. The Tasmanian government actually spends less per capita than the national average on health. So an additional $234 million would need to be spent by the Tasmanian government to equal national per capita spending. Now, I ought to note that since this slide was presented, the Tasmanian budget was handed down on Thursday, and in it, we were told, was an additional $100 million over the forward estimates for health in Tasmania. We haven't seen the detail, but we do understand that that money is an additional $100 million over 4 years. There is, of course, the very well-known Commonwealth Grants Commission, which equalises payments in recognition of a state's special health needs. We don't know exactly where that money is going. On the ground at the coalface, we're not entirely sure how much of this additional money goes to health in Tasmania. But we do have some additional particular demographic population problems, and I thank Kelly Schorf, my colleague at the University of Tasmania, for this information that I'm presenting now. You can see on the slide there that we are the oldest population. We also have the lowest number of working-aged individuals of any state or territory. We're also the poorest. Excuse me. We have the lowest average household income. And we have the highest rates of unemployment. These figures are out of date, but nevertheless, and I'm glad to say that the unemployment rate is falling in Tasmania, but nevertheless, the trend is true. Australia has the highest number of unemployed individuals. And it has the highest percentage of the population with a self-reported disability. We have the greatest smoking rates in the country. Now, every time I've only been president of AMA Tasmania for 2 years, and we had the tobacco awards last night, of course, and I'm always in dread that we will win, because we should win, because we have the highest smoking rates. We are doing something, we hope, to address that. We have the worst, by any other standard, levels of chronic disease. We have the most patients with hypertension. We are the fattest state, and that is something that I think we perhaps can argue with Queensland as to where we sit in the obesity stakes in this country, but we are certainly more overweight and obese than the national average. We have lower life expectancy. Why? If you actually look at, I knew I was going to do that at one point. If you look at disease-specific mortality rates, the laser pointer, obviously, I'll be swinging around like a whirling dervish if I tried to do this, but on the left-hand side is the age-standardised mortality rates for Tasmania. The right-hand column is the national average, and basically for every host of major diseases, Tasmania fares worse. We have higher age-standardised mortality rates for everything. And if you actually look at the socioeconomic status of Tasmania, I've already mentioned that we have the highest unemployment, the lowest per capita income. We have poor health literacy. If you actually look at the social determinants of health, I know this is one of the themes of a number of state AMAs focusing on this important issue. Social determinants of health really do make a difference, and in Tasmania we have the worst by any measure. Better socioeconomic status equates to lower rates of chronic disease, lower rates of obesity. Tasmania is, as I've already said, the fattest state, the most disadvantaged. We have the worst cancer survival rates, particularly amongst the disadvantaged group in the community. So in summary, we're basically old, fat, sick, poor and rural regional. We have high rates of chronic disease, and that is responsible for most morbidity and mortality, and our socioeconomic status significantly affects health outcomes. It is poor. Okay, what's the elephant in the room? Well, the elephant in the room is the fact that Tasmania's health system is parlous and needs reform. And there have been any number of reports that have pointed to this. The Richardson report in 2004, the Wellington report in 2008, and most recently the Bansamer report in 2014. We have 4 public hospitals serving a population of 515,000. If you were designing a health system for a state with a population of 515,000, you would not have 4 public hospitals. The hospitals are poorly performing, and I point to the AMA Public Hospital Report Card in 2015 for that statement, as evidence for that statement. We are inefficient. There is duplication, in some cases triplication of services, and there's lack of integration between the primary and acute health sectors. But it's not all as you would seem. In fact, that arrow actually points to Tasmania in terms of overnight public hospital admissions per 100,000 populations. Per 100,000 population. We actually don't spend a great deal of time in hospital, although the bed occupancy rates are very high. So in Tasmania, there are actually fewer bed days occupied per 100,000 population than the national average. Slide's not moving on now. So now of course it does. So faced with that information, the state government has undertaken a one state, one health system, better outcome reform process, and the AMA, working on the principle that it's better to be in the tent than out, is part of that process. And in it, we are looking at role delineation. What services can be provided where? We're looking at clinical redesign. We are trying to improve the efficiency of the system. We're focusing on safety, quality and efficiency. This all sounds very good, but unfortunately, Tasmania has a dubious record of parochialism, and politics on both sides has played a role in this. There is the most amazing amount of pork barrelling and politically expedient decision-making in Tasmania that I have ever seen when it comes to health. Decisions are made on the possibility of re-election rather than what is actually good for the state. Now that cannot continue in a state of 515,000, which is going to be severely affected in 2017-18 when the federal government spending on health, as we've heard, moves to CPI plus population growth. Tasmania has essentially no population growth, and how an index of household expenditure can relate to health funding is something that needs to be explained to me at least. So this is the history, unfortunately, as we come to the centenary or bicentenary bicentenary of Waterloo. There's been many attempts to change the health system in Tasmania. Whether we can do it is yet to be seen. But in conclusion, we have greater health needs than most other states and territories. We're underfunded in relative and absolute terms. The Tasmanian government needs to prioritise health spending, needs to reform health structure. If it is not done, then basically we have a major problem looming in 2017-18, which will lock in long-term reductions in funding for Tasmania, which will inevitably increase health disparity and inequity. Now, some things are inevitable. I would hope, however, although we don't know what is actually to come, that the way forward may be clearer over the next year or two, because if major structural reforms in the Tasmanian health system are not delivered, then I really fear for the future of the public hospital system in Tasmania. Thank you.
Well, thanks, Tim. Tasmania is a very nice place for a holiday, I suspect, but its health system certainly does suffer. Now, we are very honoured to have the Minister for Health in Queensland, Mr Cameron Dick, join us today. He's a former Minister for Education. We were discussing how impressive it is for people to get across the health portfolio. It is such a huge and difficult portfolio for people to get across, and Mr Dick is getting across that as we speak. He's here to discuss a state government perspective on Commonwealth and state funding arrangements for public hospitals, including the current pressures and the likely impact of changes from July 2017. Please make him welcome.
Well, thanks very much, Brian. Great to be here today. And can I begin by respectfully acknowledging the traditional owners of the land where we gather today? Can I acknowledge you, Brian? Can I acknowledge all of the international guests and visitors that have come to Queensland for this conference. Can I acknowledge all the members of the AMA? Can I acknowledge those watching the session on the live stream? And can I thank my panellists, Diane and Tim? And Tim, I know Tourism Tasmania will be thanking you for your presentation about Tasmania. Certainly, I can assure you Tourism Queensland will be thanking you. But look, thanks very much for coming here today. In a week where it's hard to be humble, to be a Queenslander, apologies to all of the New South Wales delegates after State of Origin. I thank you for making the effort to be here so early on Saturday morning. And just on Origin business, while I'm the member for Woodridge, which is in the city of Logan, which has about 340,000 people, and we have one hospital, which is interesting compared to the numbers that Tim was talking about. The most famous Cameron ever to come out of Woodridge is Cameron Smith, who's the captain of the Queensland Rugby League team and the Australian National Rugby League team, the Kangaroos, and I know who the most popular Cameron is in Woodridge. But let's get on with the business of the day, because funding for our public hospitals is a very serious matter. Before I talk about the cuts made by the Abbott government, I'd like to go back quickly and look at the history of funding for public hospitals over the past 30 years. There we go. This first slide shows data from the Australian Institute of Health and Welfare dating back to 1985-86. It shows the Commonwealth's share of recurrent public hospital expenditure in blue, which is the bottom line, going down, and the state and territories' share in green, going up. The measure of public hospital expenditure includes Commonwealth spending on such things as private health insurance and Veterans Affairs when it relates to the public hospital system. Now, the Howard government made changes to the way the Commonwealth government funds public hospitals in 2003, which resulted in a decline in the Commonwealth's share of funding. The pattern is even more stark when you look at the funding shares for just Queensland and the Commonwealth, as seen in that next slide. In this case, the data only goes back to 1996-97, but the trend is clear. By 2007, hospitals around Australia were showing the effects of the Commonwealth's underfunding caused by the Howard government's changes, and voters were noticing. It was in that context that Kevin Rudd promised Australians before the 2007 election that he would end the blame game between Canberra and the states on health and hospitals. And after years of consultation and negotiation in 2011, the Commonwealth and the states signed the National Health Reform Agreement. Under that model, as you know, the Commonwealth agreed to fund 45% of efficient growth in public hospital services from 2014-15 to 2016-17, and then 50% of efficient growth from 2017-18 onwards. Now, this agreement was signed not only by the Labor Prime Minister and the Labor Premiers of Queensland, South Australia, Tasmania and Territories. It was signed by the Liberal Premier of New South Wales, Barry O'Farrell, the Liberal Premier of Victoria, Ted Baillieu, and the Liberal Premier of Western Australia, Colin Barnett. 2 years later, in 2013, Tony Abbott promised Australians before the federal election that there would be no cuts to health. He then broke that election commitment in his first budget by changing the way the Commonwealth provides funding for public hospitals. The budget papers claimed that they were making spending arrangements, quote, more sustainable, end quote, when they were clearly just cost shifting from the Commonwealth to the states and territories. The recently released federal budget confirmed that these funding cuts will go ahead. Under Tony Abbott's proposed formula, federal funding for hospitals will only grow in line with population and CPI from 2017-18 onwards. The problem, of course, with this formula is that it doesn't take into account other factors that drive health expenditure, such as the ageing of the population and technological change. In Queensland, we're no different to anywhere else in Australia in that our population is getting older. A decade ago, 12% of our population was aged 65 years and over. Now it's 14%, and in a decade it will be 17%. You know better than me that if you take 10 people aged under 65, their call on the healthcare system will be considerably less than 10 people aged 65 years or older. Tony Abbott's change will shift the full burden of the ageing of the population onto the states and territories, rather than sharing the burden 50-50 as would have been the case. If the Abbott government's argument is that the Commonwealth can't afford to share 50% of this burden, then how on earth could the states afford to carry 100% of that burden? Tony Abbott's proposed formula also takes away the incentive for governments to work together so patients are treated in the most appropriate setting. Now, the Commonwealth Treasury released figures last year which show the nationwide impact of the Abbott government's cuts, and Brian's touched on those earlier. The figures reveal that the changes will reduce the federal funding for hospitals nationwide by $57 billion from 2017-18 to 2024-25. As you can see in this slide, the impact gets worse and worse every year because of the nature of the changes. Now, my department has estimated that Queensland's share of these funding cuts on a population basis will be $11.8 billion over that period. And my department is currently modelling the impact that these funding cuts will have on hospital services and the future health workforce. This work is still at an early stage, but I'm pleased to announce some of those preliminary findings today. This slide, slide 5, shows the projected Commonwealth share of national efficient public hospital expenditure from 2013-14 to 2024-25. This is a different base to the first slide I showed, which included Commonwealth funding for such things as private health insurance. But as you can see from this slide, that under the model agreed in 2011, the Commonwealth's share would have risen from around 33.5% in 2013-14 to nearly 42% in 2024-25. Under the model proposed by Tony Abbott, the Commonwealth's share will start to decline when their changes take effect in 2017-18, falling to around 32% by 2024-25. The funding cuts will obviously have huge implications for our future health workforce. My department has modelled the number of health jobs in Queensland that would have been funded by the amount of spending being cut by the Abbott government. Their modelling is based on the proportion of hospital and health service costs going to doctors, nurses and health practitioners in 2013-14, which was 16% for doctors, 26.5% for nurses and 8% for health practitioners. As shown in the slide on the screen now, the impact in 2017-18 is 164 doctors, 580 nurses and 165 health practitioners, and the impact gets worse and worse every year, as we've previously seen. By 2024-25, the impact is around 1,500 doctors, around 5,300 nurses and around 1,500 health practitioners. Now, it's obvious that I'm part of a state Labor government and they are a federal Conservative government, but this issue is more about federal-state relations than partisan political issues. That's why Queensland is seeking to unite with other states in calling on the Commonwealth to reverse the cuts. I also want to thank the AMA for championing this cause on behalf of its members, but more importantly, Australians. As doctors, you would know more than anyone else, you would understand that these numbers aren't just numbers on a graph. We're talking about people's lives. These are vital funds that deliver everyday public hospital services that support Queenslanders. And these types of unilateral decisions by the federal government are incredibly damaging to confidence and capacity in the health system. By contrast, our government in Queensland, the Queensland Labor government, is committed to doing our best to be a consultative government. One particular area that we are focused on is wages and conditions for Queensland's health workforce. The government is committed to the right of all government employees, including doctors, to collectively bargain. We won't be repeating the appalling antics of the previous LNP Newman government in Queensland, which attempted to steamroll anyone who had a dissenting view. Instead, we will re-establish collective bargaining and enterprise agreements for doctors as part of our industrial relations policy agenda. Earlier this month, the Treasurer and Minister for Industrial Relations in Queensland introduced legislation into our state parliament to start this process. And the Department of Health is now working on the process of identifying an approach to transition medical officers to collective agreements. Our commitment in the election was, and our commitment now, is to deliver on that election commitment to restore rights stripped away by the Newman government. Now, as I said earlier, the AMA is a key partner and stakeholder in our health system. We want to work with you. We do want to work with you to improve the health system and to get the best outcomes of Queenslanders. I look forward to answering your questions this morning and to working with you in the future. But before I do that, I wanted to show you one last slide. Now, I've learnt as the Minister for Health, being happy has an impact on your health and well-being. This slide doesn't have much to do with anything we're talking about today, but it makes me feel happy. Thanks very much, everyone.
Thank you, Minister. Okay, so it's time now for some questions. We do have, we've got the instructions there on the screen. Some questions have already come through for the panel. The first one is from Sarah Whitelaw. How do we ensure that education is both a KPI and funding priority for our public hospitals in the current service provision driven environment? And where does the federal and state government responsibility divide lie in the future? Who wants to answer that?
I can take a go. That's education.
Yeah.
Was the question? The question was around education and making it a KPI. Currently, we have in the country what's called a performance and accountability framework that drives uniform reporting topics that the National Health Performance Authority reports on all public and private hospitals. In that collection of measures that was agreed in late 2011, education, training, and research was not in there. And I spent a lot of time in my first year on the job trying to understand why that was the case and what to do about it. The Performance and Accountability Framework is being reviewed this year. So if you want information such as education, training, and research, and this is the year to ask the governments to put that in their collection of measures of performance for hospitals.
Could I also add that I think that the individual doctors, particularly senior clinicians in teaching hospitals, have a responsibility here. Teaching hospitals are called that for a reason. We are training both medical students and our next generation of specialists. And it should be part of everything that you do. It should be fundamental to everything that we do in working in a teaching hospital environment, and we should resist any attempt to reduce the role that teaching plays in our hospitals. And certainly in my institution it is part of the expected template for a staff specialist, for example, to have dedicated time for teaching and also research. And I think we must fight to maintain that, otherwise it will be to the detriment of the public hospital system.
Minister?
And just to, I suppose, follow up on what Tim said, in Queensland, the recent development and establishment of hospitals has been focused around those hospitals being teaching and university hospitals. So the new Gold Coast Hospital, which the Labor government initiated, is the Gold Coast University Hospital. We're now reaching completion of the Sunshine Coast Public University Hospital. That's the first new hospital built on a greenfield site in Australia for about a quarter of a century, as distinct from a redevelopment or an amalgamation of a hospital or hospitals. And that will have a university focus. We are looking, we've had some challenges. I think for Queensland clinicians and practitioners will know that we've had some challenges with locking down the university partner. The University of Queensland was our partner originally. They've now withdrawn, so we're looking to settle that. Happy to work with the AMA on that, and we may need to list your support, but the Labor government sees that as critical. To answer the question how we embed that, I think is an important question. I don't have an answer for you today, but it's an important aspect of what we do in our hospitals, and how we roll that out in the future I think is important, and Diane no doubt will have a role as leading the NHPA in that space.
Thank you. Okay, question from Omar Khorshid. Regarding hospital performance, how can you be sure that the reported variations are real and not a result of bad data? For instance, it is difficult to believe that a hospital could be performing total knee replacement for an average of $10,000 when the cost of the implants alone is close to that figure. In Western Australia, cancer waiting times that are reported are much lower than what the patient actually experiences. Perhaps more effort is needed to ensure targets are clinically appropriate, e.g. cancer referral to definitive surgery time, and that there is no gaming by hospitals or health departments. I think that one's for Diane.
I love this question. I guess asked it all the time. This is a big industry measuring and reporting on the performance of hospitals and health services, and we take our work very, very seriously. So one of our mechanisms of ensuring quality is we could ask you to turn to the person next to you and ask that person, is your data good and are you gaming? But we don't do that. So let me tell you some of the things that we do to ensure quality of information. First of all, information is fed back to clinicians on a regular and daily basis. So if you see information on a monthly basis, for example, about your wait times or your length of time in ED, and you don't think it's right, then you should take some action. Right, because that information gets aggregated across the year, it goes to your state, and then it goes to national organizations, etc. At the state level and even at the national level, we undertake audits of data. This happens routinely in jurisdictions, and when we see a need to do it, for example, as the 3 independent audits that were done nationally, national organizations do that in partnership with our state and territory colleagues. Those 3 independent audits of the National Cost Information System were done explicitly because we were going to run models on activity-based funding for the National Efficient Price and use it for public reporting. So those audits are routine and ongoing at the state and happen occasionally across jurisdictions in collaboration with national entities. If we see shifts in performance, as we saw, for example, in Princess Alexandra, we talk to the department, and the department tells us what's going on, and they talk to the hospitals, and they tell us what's going on. We actually look in the underlying data, and the patterns of care and flow of patients that we saw in the data in that hospital in particular matched the stories that we were getting from the hospital. The state verified it with the hospital, and we verified it with the state. Some of the other information tricks that we have, for example, going and looking at appendicitis, okay? How accurate or inaccurate can be looking at length of stay for appendix removal? You have one DRG, they were there just for a few days, they were there for that, you know the day they came in, you know the day that they left, and so unlikely to be gaming and unlikely to be playing with information. If you do see, lastly, if you do see results from national reports that differ, and you see it in the newspaper and they differ from what you know locally, I'd encourage you to get that report out, because there is some instances, for example, where we have to do things a little bit differently in terms of measurement nationally than you do it within your state. And the reason for that is sometimes there are differences in the way that you can measure in a state when you have to measure right across all states. So one example was the wait times in cancer. This wasn't just breast cancer, this was malignant breast cancer. So if you're looking at wait times, for example, for breast cancer in your area, and they look different than our report, it's because we looked at malignant cancer. So if you see some of these differences in national reports from what you understood locally, please get the report out. We release all of the details and technical supplements about how we measured, and we're able to do that in a nationally consistent way.
Just, Diana, just sort of supplementary to one of the questions that was asked there, this question of referral to treatment time. The AMA often talks about the hidden waiting lists, you know, the time that it takes, particularly in the public hospital system, to be seen as an outpatient and then actually get onto a surgical waiting list. That time is not measured, and in some cases can be in the order of years. Yeah. That was a recommendation of the COAG expert panel that was looking at NEAT and NEST, Is there any progress on that, or is that something that you plan to look at?
I would say some progress, yes, but not at the speed and not exactly what you asked for. There is some progress in the sense that on our website now we have information on wait times for GPs and wait times for specialists. Now, those are wait times for all the people that were waiting, not necessarily all the people that were waiting and that subsequently were referred for surgery and then subsequently got that surgery. To follow patients who received surgery and to go back upstream requires linked information systems. And you'll remember the presentation yesterday from the former president who talked about the work at NETA. And while we have come a long way in the nation in setting up unique patient identifiers and national standards for being able to link data and to measure it across systems, we're not there yet in terms of implementing that uniformly across jurisdictions, even though you see a lot of movement within jurisdictions. So the national comparative reporting comes last. After you have the standards, you implement them, you have consistency across your state, and you have consistency between the states, and then you see the national reporting. So there's progress, not as fast as you would want it, not as fast as I would want it, but there is progress.
Minister or Tim, any comments on that question?
Well, we do report on that data. Well, I think we're one of the few jurisdictions that reports on what's happening with those people waiting for specialist outpatient appointments. It is always a perennial concern in the community, but I think we need to be, I've said publicly, we need to be realistic and genuine about it. And there's been a lot of debate for those of you outside Queensland about elective surgery and wait time guarantees for elective surgery. As at the 1st of May this year, 209 people were waiting beyond clinically recommended time for surgery. In Queensland, 100,000 people are waiting beyond clinically recommended time for an outpatient appointment in a public hospital. And so the political debate in Queensland's been around the 209 people and supposed guarantees that they would be treated. As a minister that's interested in equity and affordable healthcare, but ensuring that everyone gets the healthcare they need, I can't abandon the 100,000 people who are rightly very angry about talking about 200 people, and we can't have a system that favours the many, the few and not the many. So that's a challenge. I think standardising how we report nationally, I think, has been really important. I think there's been a big shift since the National Health Reform process started, and that's I think been of assistance to everyone in the health system. And I think if this could be rolled out on a standardised national basis, it will be difficult to do, I acknowledge. I think that would be a great thing for our nation, and I'd support further work in that area.
Okay, thank you. Next question is from Jeff Louis. What approaches can be taken to effect attitudinal and structural changes in the context of small regional health service parochialism?
Can I?
This is the one for you,
yes.
Tim.
Given that I've raised it, it is a real issue in Tasmania. It is an ongoing issue. It is one that's attempted to be addressed by community consultation. So as part of what's been called the white paper draft discussion process, there's been a series of community fora that have been held around Tasmania to try and engage the population to explain that you can't have your hemorrhoids and heart transplant done at the same hospital down the street. You know, you have to have surgery, particularly complex surgery, done in centres with high volume, with standards of care that are appropriate. And it's an educational process that we're embarking on, but we are meeting an awful amount of resistance. I checked my email yesterday, and the Mayor of Devonport has come out already saying that the Mersey Hospital has to have its ED, has to have its HDU, has to have a standalone maternity service when there's one in Burnie without any paediatric support. Now, this is disastrous kind of posturing for local parochial political purposes. And the AMA has a leading role in standing up and educating and standing up for what is right. Whether we're going to be successful or not in a Tasmanian context, I have no idea, but we're in it for the long haul.
I think it's a good point, and our hospital and health service system in Queensland, which is now has devolved authority, there's been through that system, there's been a number of honest conversations about what services can be provided locally. I was in Gladstone this week, and the community there has worked across the system, so the private system, the Mater, working with the public hospital, which had been a problem historically, really staffed by locums, which is not a sustainable way to deliver hospital services in a local community. And also some good corporate citizens in Gladstone have worked on a One Health program for Gladstone, and they've agreed effectively the type of surgery that can be performed at Gladstone Hospital and at the Mater, and the community has signed up to that. Some of the high level tertiary services surgery won't be provided there. So I think those honest conversations are really important. People do want local services provided locally, and delivering those is important for Queensland, which has the largest and most decentralised, the largest decentralised population in Australia. That's a really significant issue for us. But if you take $11.8 billion out of the system, it simply won't be possible to deliver more services to more local communities. That will not happen, and that will be the challenge. Try to get Queenslanders to understand that, because we simply won't. You've seen the number of doctors and nurses that we might have been able to deliver. We won't be able to do that, and so that's the challenge over the next 10 years for our state. But having those honest conversations, I think, is important, Tim.
Thank you, Minister. Okay. Given the projected budget deficits, the Australian Government is unlikely to fund the needed growth in public hospital expenditure. Is it time to look at the Federation and either a single funder for health, or at least give states the ability to raise enough money to fund their responsibilities? So I guess that comes back to the Federation White Paper in some respects. Probably one for you, Minister.
Yeah, thanks for that easy question to answer. But an important one. And the Federation White Paper hopefully will be a genuine approach to shaping the future of our federal nation. I'm a little sanguine about the position the federal government's taken. If you're saying in 2 successive budgets that this system is going to change unilaterally after that entire process of engaging deeply to set the framework, and then you just change it unilaterally, well then I'm a little bit concerned about the genuine engagement with that process. But Queensland remains open. We are going to engage very closely with that Federation White Paper reform, and there will need to be a discussion about what's next. If the Commonwealth is not willing to go down the path of national health reform that we thought embedded, it's never too late to change, and hopefully the state and territory First Ministers can have that honest conversation at the Leaders' Retreat in July, and then at subsequent ministerial meetings, then there may be a chance to change that. But it's very disappointing, as you've heard from my comments today, very disappointing in how that process has suddenly changed without that deep consultation that I think is needed in health. We're not going to be able to do it. We can't raise the money to fill the gap. How we get to that, answering that question of single providers and single funders, I don't know. That's fraught in some ways because of the politics involved, but I think those things are on the table, and the First Leaders will have probably a very deep conversation, hopefully in July, about that.
Okay, I might go on to the next question. Easy one for Diane, from Ross Kerridge. How secure is the future of the NIPA as a service for the public and ensuring integrity of data?
I'd say you can probably answer that question better than I do. I don't have a crystal ball and can't tell you about the future any more than you can. But if you see that there's a need, then you can help shape the future just as you do in other areas of policy and practice.
Okay. Might combine two questions here, one from Richard Kidd and one from Kathy Hutton, again for Diane. In looking at data of duration hospital bed stay, do you link it to monitoring outcomes such as readmission rates where patients have been discharged prematurely or without adequate transfer of care arrangements to the GP or primary healthcare team? And Kathy was asking a similar question, I think. Given that most patients are discharged back to their homes and GPs, is it possible to have reporting on data related to clinical handover of care at discharge?
Fantastic questions, and wish I could do both. We've released for the second year in a row information on length of stay for 16 clinical conditions, and it's on our website now for more than 400 public hospitals. We have undertaken to start some work on readmissions. I know from having done that before in 2 jurisdictions, it's much more difficult to do than one would imagine. That said, it's even more difficult in Australia because of the need, again, to link information systems across patients and across time, which is difficult for the reasons that I described a few minutes ago. That said, you now have that information across 16 clinical conditions for more than 400 hospitals in the country, and you now have the establishment of these primary health networks who will be very interested in supporting your work through the clinical councils that will be established to bring together the primary care community and the hospital community. And if you're interested in reducing length of stay in hospitals and you think that the ticket for your local community is better traction between the interface of hospital and primary care to reduce length of stay while optimizing patient outcomes, that's the next vehicle to be using our information to get some traction for change in your local areas. I think will be these clinical councils being established for the PHNs.
Can I just ask a supplementary question to that? A couple of years ago, a paper in the New England Journal looked at the readmission diagnoses for patients who had unplanned readmissions to hospital after an acute episode, and 2/3 of the readmissions were not due to their original complaint. Hospitals are dangerous places. I know I work in one, and they, for a variety of reasons, cause the vulnerable, sick, elderly patients harm. Are you going to be able to track the reasons for the readmission, not just that they are being readmitted? Because I think that data is incredibly important.
I have done readmissions before in Australia. It's when I worked at the Bureau of Health Information in New South Wales. And what we did there, which is an approach I would recommend when we get there to do this nationally, is you start by using clinical conditions rather than readmissions writ large. And in the Bureau of Health Information, we did that with COPD and congestive heart failure. We did all that work with the New South Wales Bureau Agency for Clinical Innovation with all the clinicians. And we saw some of the things you were talking about earlier. So, for example, the data got so confusing, we said, let's just take a random sample of 100 patients, track them across time, anonymize patients, you can identify who they were, and see about these patterns. And I'll tell you, you go to this hospital, they'll call you COPD. 1 week later, you're admitted to that hospital, they call you asthma. 3 days later, you're admitted to that hospital, and they call you COPD again. You go back to the first one that called you COPD, and they call you asthma. Right? So you do this work very carefully, my point from earlier. You do this work with clinicians. They tell you about the interval of time that's material for that condition to be related to the first admission or not related to the first admission. They enable you to deal with the issues about doctors either someone has asthma and then COPD within a week, or doctors call it one thing and another, or code it one thing or another. And this is how we deal with those inconsistencies in coding, to create at the end of the day reports that all the clinicians that we work with can stand by and say, in general, this is the patterns of care that we see in our local hospital.
Okay, next question is from Gino Pecoraro. Meaningless private health insurance means that people with PHI are filling public hospitals, removing capacity from people who have no other option. Is it time to means test, access and reform private health insurance? Well, certainly the junk policies, as I've referred to them as, for private health insurance, which covers people only for a public hospital, not a private hospital, don't seem to be very effective, rather than just avoiding paying a tax surcharge. Who wants to comment on that one? No.
As you should.
Well, yeah. Well, you know what?
Exactly.
Brian.
We'll give that to you, Chair.
Yeah, thanks. Well, I think it is time to reform private health insurance, and certainly those junk policies have no place. You know, we can't have people that think that they can, first of all, jump a waiting list because they're privately insured and they're going to a public hospital. You know, if you're actually going to have private health insurance products, they need to be meaningful. They need to not have a whole bunch of exclusions on them, which makes them essentially worthless. And there are certain funds that are very, very guilty of doing that. And they market themselves on all sorts of other ancillary products, which are completely useless to the patient. You've got to get back to actually us being able to identify what the value of the private health insurance product is, and I think we can play a role in assisting people understand that. Anyway, next question is, sorry, oh, hang on. Next question is from Dr. Paul Neeskens. It's to Diane. Given Professor Brooks' funnel in 2030, there will need to be decisions made on cost effectiveness. Could NIPA have a role for reporting other perspectives of performance, i.e. dollar quality? There will need to be data and understanding that an intervention is just too expensive, will just have to be made. Good complex question. The Performance Authority has only been around for 2.5 years and been reporting for 2 years. We went from nothing to something, and everyone wants to put all the data together, as you should, because that's where you get the most value. We took all of the indicators one at a time to do the best that we could in terms of making the data nationally consistent, measuring it in a meaningful way, and releasing it in meaningful ways. You can now, and we just added the last piece of the puzzle for public hospitals around efficiency. Started with access, we moved into quality, and now have some information and efficiency. It's still not as much information as you would want, or as much information as I would want to report, but we're only 2 years into this. This is the year, however, as I mentioned earlier, that if you want other or different or better measures of outcomes for patients, either in local communities or in hospitals, is to let us know, or let your jurisdiction know, what you think above and beyond what we've done already that would be most useful to meet your evolving needs for information about local communities, for PHNs and the regions within them, and about public and private hospitals. If you're interested in things like quality or price for quality adjusted life years, ask for it. This is the year to do that. Okay, great. Okay. Yeah, so there is compelling evidence. This is a question for the Minister. There is compelling evidence that investment in primary healthcare delivers substantial savings and reduced demand on secondary and tertiary services. What are you anticipating to do in this area?
No, a really valid point, good question. We want to work closely with the new primary health networks that are being rolled out, and I've spoken to a number of the chief executives of those entities about how we do that better, and engaging our hospital and health services with the primary health networks. I think that's a real opportunity to get that up and running very effectively in Queensland, having spoken to Sean Rudd and others, I know they're very keen on making sure that that new system works effectively. The more we can get services out, I think, into the community through GPs, I think the better our system will work overall. Some of the Queensland delegates will know as an example of how I think we should better upskill GPs, so they're working at sort of at the full extent of their scope of practice. We've announced $30 million to try and address the wait list for ear, nose and throat treatment, which is a really big problem in our hospitals. People waiting, for example, in Logan Hospital, 4,500 people waiting more than 2 years to get an appointment as one area. So we're really trying to address that, and we're working with the college there. Bernard Whitfield, Dr. Bernie Whitfield's been very helpful to us in scoping that out and working with that. But as part of that, one of the things Dr. Whitfield has suggested is talking about using some of that money to train local GPs, to upskill GPs. His numbers on, I think, are quite interesting on the amount of training GPs get during their undergraduate degree, and then as through their subsequent training is quite limited in ENT, but I think he told me about 30% of presentations to GPs are often related to ENT. They're the rough numbers he gave me, and he's trying to look at using some of that money, the $30 million, to train local GPs to deal with some of the treatments that can be done in a local GP surgery. I think that's really smart thinking. I think that's really shrewd thinking. I think he's had 17 referrals in one day to him in his public practice at Logan, dealing with, and I'm sorry, you'll get the fact that I'm not a doctor, dealing with sort of a chronic nosebleed that happens in elderly patients, elderly Queenslanders, that can be treated through a cauterisation type process in GP clinics. And that would be something that would mean those 17 referrals would come off the 100,000. So I think working in a smarter way with GPs, I'm very open to that. I look forward to working closer with the AMA on that, because I think that's, with technology advancing, with really skilled GPs, I think that's the way of the future, and takes the pressure off our hospital and other institutions in the system. So I think that could be a very effective way to move forward. I hope that answers your question.
I think Diane was going to make
Yeah, I wanted to make a comment on this, because I'm really excited about this opportunity with the PHNs and the governance structures, to be able to provide information to those people. I'll tell you, when we were established at the same time and kind of lagged the establishment of Medicare locals, when they had to complete their needs assessments, it was in and around December 2012, and we were releasing our first report on hospitals and could give them no information about nationally consistent comparative information about their local communities. The information on My Healthy Communities website is so rich now. 130 measures of health and care down to very local communities is a rich resource for PHNs, as well as the information on length of stay, for example, in my hospitals. The work that we're doing right now that will be released between about August and September with MBS information and PBS information around prescribing patterns will be unprecedented in my career, and my history has been in working in primary care information systems to provide data. Unprecedented insights about variation in care patterns in primary care across the country. What will that do? It will allow you to look across all of that information for your local community and make more information-informed decisions in tandem with your community and clinical engagement around priorities about where you can spend the resources and time and quality improvement effort, energy that you have to make an improvement. And I just got a call last week from you made me think of it, what I wanted to say when you said about the chief executives for all the PHNs. There's 7 of them in Queensland, and they called me last week and invited me to spend 2 hours with them on their second meeting, because they are so energized by the amount of information that we can give them that they can use to begin their engagement processes with community by juxtaposing this information, nationally consistent, comparable, about the profile in their community, engage with the community about its priorities, where it wants to spend its attention to be able to finish off their needs assessment. So I'm just really excited about being able to contribute to that reform agenda with information.
Well, thank you. It's time to draw this session to a close. There were lots more questions that were coming through that I'm sorry we didn't have time to get to, but we had 3 excellent presentations. Thank you to each of our presenters. Please join me in thanking them.
We filled up the room. Thank you.
Oh, thanks very much. That's lovely.
Thank you to Brian and his panel for a wonderful session. And it's time for morning tea. Can I remind you before you go that the urgency motions will be debated this afternoon at 4 p.m, and that's a change to the program. So urgency motions debated this afternoon 4 p.m, and we'll see you back here at 11 o'clock. Thank you.